Yes. So thank you again for listening to this conversation, the second conversation with Victoria Brazil. And that is because I had the feeling that I was knew a little bit about simulation training, but now some new terms are coming my way and our way, like translational simulation training, we have in situ simulation and so on. But before that, we move in. First, a short introduction, and this is from the SESAM lecture biography. Victoria Brazil is an emergency physician, educator, simulation specialist, and healthcare team coach. She's a professor of emergency medicine and medical director of the simulation service at Gold Coast Health and leads the Bond University, there we go, Translational Simulation Collaborative. Sorry for my English. Victoria's main interests are in connecting education with patient care through translational simulation in healthcare and developing high-performing healthcare teams. So there we have already a lot of difficult words, and maybe it's nice. I also came across your keynote, and it was called at SESAM in Prague. It was called Framing the Use of Simulation for Healthcare: Rethinking Purpose and Process. You also wrote an article about simulation training, which you sent me. I'm not sure if they are all connected. Your lecture.
Very connected, yes.
Very connected. So, well, just let me ask the question. What are we talking about? And you can do it from the point of your lecture or the article. What is happening in simulation training?
Yes, thank you, Eric. And it's a pleasure to be here again. So yeah, let's dive into it. Translational simulation, what do we mean? Well, wind back a little bit, and the conversations you and I have had before, and lots of the work many of us have done in simulation, has been focused on training people and training teams. So it works in what I would call an educational paradigm, which means we create a simulated environment and we work on thinking, what do our doctors, nurses, police officers, military people, what do they need to learn? What skills and knowledge do we need to train them in? And simulation is really good for that. And I do lots of that kind of simulation, and it's very good use. This builds on that paradigm, but is distinct from it. So this use of simulation says, one of the other things that affects performance, whether that's patient outcomes or whether that's performance in your kind of settings, are systems and processes. And maybe simulation can help us test and improve and understand the systems and processes in which these individuals work. So yes, they need to be well trained, but we also need to put them in a system and provide them with processes of care, in healthcare's sake, that allow us to do the job well from the point of view of the end outcome.
Yeah.
So I'll give you an example in our world. So let's say we need to be doing a resuscitation in the emergency department. So of course we need to train our doctors and nurses and other health professionals to be good at their part in that. But some of the other things that affect performance are, and I know you did a podcast with Andrew Petrosoniak, might be things like, what is the physical environment? Where is the monitor? Are people able to see it when they're actually doing the procedures they're doing? Have we set up the equipment in the right format that people can get to what they need easily? And then if we get to the system level, what kind of processes are there for calling the surgical doctors if we need them for this resuscitation? What kind of processes are there if we need to move the patient to the operating theatre? How do we get that happening quickly? So you can see that these systems often are just as important in terms of influencing performance as the knowledge and skills. It's one thing for you and I to know how to do something, but to get it done for that patient in that environment, in that hospital or in the field even, requires a lot of thinking about what is the environment that surrounds the people that do the work. So one of the things, yes.
It looks. There is a quote. I'm not sure. It's from James Clear. The environment is an invisible hand that shapes performance, or something like that.
Beautiful, exactly. And that environment in healthcare is complex.
Yeah.
And this is one of the things which makes this kind of simulation so important at this point in our evolution in healthcare. If we think about the journey of just a single patient, say, who arrives in the emergency department with a heart attack, there's so many interfaces, not just with the healthcare professionals, but with the systems and the environment, that it's incredibly complex. So simulation can allow us to explore what's happening, what's getting in the way of good performance, or what's working well that we need to do more of. But it can also help us test if we think there's a better way. So let's say we wanted to have a little checklist for knowing if all the right treatments have been given to that patient with a heart attack. Well, let's set up a simulation and let's try one checklist and see what people think. And maybe it's good, maybe it's not so good. Well, let's try another one. Let's do another simulation and try out a different kind of checklist and see if we can refine it. And if you can see, the benefit of simulation here is that we can do 50 heart attacks in a day in a simulated environment, and we can test things quite quickly and iteratively. Whereas if we were waiting for real patients to come in, number one, we don't really like trying out experiments on real patients. And secondly, we just don't have the volume in some cases to be able to do this kind of testing of some of the systems. Now, where we saw this, so I first came up with this terminology in 2017 and wrote an article then. And the most recent paper that you allude to, we looked back over the last 7 years and thought, well, what have people been doing in that time that are examples of this kind of work? And Andrew's design thinking for the emergency department environments is one example of that. But the changes we had to make to our systems of care in COVID has been a very big example of that. Because what happened was, in healthcare, we had to change a number of the things that we did so that we would be more COVID safe.
Yeah.
Things like wearing personal protective equipment, but many other things as well. Things about separating the numbers of staff that we might normally have in a cardiac arrest, thinking about the patient transit so that we didn't expose other practitioners and patients to a COVID patient. So we had a lot of new systems and processes. And a lot of people wrote them down in guidelines, and that was good work to do. But as you might imagine, the 15-page guideline may well have been correct, but it may not have been feasible for the healthcare practitioners to use in real time. So we saw a lot of places using simulation to try and refine these systems and protocols very rapidly so that they were fit for purpose, they were effective, but they're also feasible from the point of view of the healthcare practitioners. So COVID was one good example. Design thinking is one good example. And the other example we've seen is when people are building new hospitals. This is obviously a very effective thing to simulate the kind of workflows we might do in those new environments and see if they actually work. They seem quite good on paper, but do they actually work?
So if I summarize a little bit, you can use translational simulation to explore, and you can use it to test. But how about maybe it's an old term, but let me use it, fidelity, because I can imagine that if you are testing something or exploring something, it's you can make a case that it's important to do it with the people who are involved in reality also, and materials and so on. How does it fit into exploring and testing the fidelity, realism?
Yes, that's a great question, Eric. And I think what it does, and that's the second part of the talk you referred to, the purpose is one thing, but what's the process by which we do this kind of simulation? And the first step is to think really hard about what is it that we are testing. And then to think, depending on what that is, which elements of fidelity are most important. So for instance, if we are testing the ability of different teams to come together around a trauma patient, then you're right, we want those real practitioners. We probably want the real physical environment, but we might not need a real patient. So you start to think, well, which bits of it need to be real? If we want to test the physical movement of that patient to the operating theatre, you're right, we do need the real wardies, porterage staff. We do need the right clinical staff. We do need to actually move the patient from the emergency department up to the operating theatre into the right room, through all those interfaces. But again, maybe we don't need a real patient. Maybe we can use a mannequin. Maybe we can put a plastic laminated representation of a patient on a bed and just push them around. So you start to see we need to think really hard about what's relevant here. If we're just testing a checklist, though, maybe we can do that in a desktop simulation. Maybe we don't even need to do that with everything else around it. So maybe we can do that quite efficiently in a tutorial room with some doctors and nurses involved in airway management. Maybe they're real equipment we might bring in, and maybe even we'll have a mannequin, but we don't necessarily need to be doing that one in situ. So that's where purpose, I think, is where our conversation is at now. I think most people can get on board with that process.
Yeah.
That purpose. I think most people can go, yeah, obviously sim to test and explore, and that makes sense. But to think about how we do it, I think, is where the cutting edge of this field of simulation is at the moment, because there's lots of good questions like the ones you ask.
So if I combine this with my conversation with Andrew, who uses design thinking, is design thinking then one answer on the how to do it?
It totally is. And again, that latest article, what we did was we had a diagram in there that is a conceptual framework for how to think about this. So we've got the purpose, as you rightly said, to explore and improve. And then if we look at the process, we start to see that depending on what it is we're trying to do, there's a number of conceptual frameworks that we might draw upon. And design thinking is one of them.
Can I put on the... You had a diagram in your article with the colors. Maybe I can.
Oh, great. That would be a good idea.
Wait a moment. This is performed under pressure, of course. Well, I think it has...
I think it's probably the figure 1 in there.
Yeah, but I now have to find the sharing screens.
Oh.
Where can I
should
find
be
it?
share content in there.
Share content, but where is share content? Wait a moment, maybe here. No. Oh, yeah, I found it. Okay, now I have to. Yes, I think this is the right. Maybe can you see it?
Yes, that's it. Thank you. Would you like me just to speak to that now?
Yeah, maybe because I think it's so they can watch again. Yeah.
Absolutely. So if you see, as I said, in the yellow there, you can see the purpose, as we've just been describing, exploring the healthcare work and improving those teams and systems, just as we've been discussing. And so then you're quite right. We turn our attention now to the blue boxes in the middle about process. And you can see, depending on exactly what it is that we're trying to do, we might draw upon some of these frameworks and also some of these methods and tools. So design thinking, as we know, is a specific methodology that is designed, that is very good at helping us test, rapid prototype, new ways, new places, new systems. And so that is one particular methodology that I think is very helpful as we think about how to do this. There are other methodologies, though, as you can see both in that list. If you were, for instance, working on team culture as one of the environmental things, you might have a somewhat different approach, and you might be looking at team development interventions.
Yeah.
And you can see that those methods and tools are drawn from the white writing in the blue that is the border around this diagram. So you can see that there's a lot of fields of practice here that have these methods and tools, whether it's safety science, whether it's organizational behavior, systems engineering. You can see the learning sciences are in there, but there are other ways of thinking about improvement that we would draw upon as we thought, for me, doing a specific translational simulation program, what would I be using as my methods and tools in order to fulfill the purpose that I would like to focus on.
And say you are a doctor, medical specialist involved in education, training, or even making your healthcare better, or a simulation specialist. Can we, from this conceptual foundation, can we make a very simple, how do you call it, example of how can we use it in very simple, non-complex way?
Yes,
So
sure. Yes, so I think there's be a couple of other examples that we might do, and maybe I'll take one of our own. Let's say you'd like to look after the patients that deteriorate on the ward better. Now, that actually is quite complex. So let's say your average patient, they've had surgery, but then their clinical condition deteriorates. And hospitals have various systems in order to recognize that patient as needing more care and then to respond in the appropriate ways. So let's say you decided, okay, I'm going to look at that in the hospital. So let's firstly run some simulations that might help us explore this. So they might need to be in situ, they would need to involve the real care practitioners, and we would set up a simulated patient who had deteriorated. And we might run that simulation, do some observations. We might ask some of the participants about what gets in the way of doing this well. We might look at data that we collect during that simulation, like how long it took for different interventions to happen and how long it took for that patient to get to the ICU, if that was appropriate. We might look at the quality of the communication in there. So you can see that there are still some of the things that we would have focused on in a purely educational simulation, but we start to see that we're also exploring those systems and processes. Now, to your earlier point, we wouldn't abandon data from the real world. We would obviously also have information from audits and from other sources that might also help us understand and explore what goes on and what gets in the way of better in the care of this deteriorating patients. But let's say then we'd done this simulation series, we'd combined it with some of the data from the real world, and now we said, here's a couple of things we'd like to try out to see if we can make it better. Let's say one of those things was to change the call systems. Let's say one of those things was to change the team leadership. Let's say one of those things was to create a cognitive aid for the team leader when they arrive. And then we might run a series of simulations, some of which would be in situ, but some of them we could actually do in a simulated lab because we were focusing on some issues other than purely the environmental ones. And so we would run a series of simulations, and in each of those we would collect data from the participants and from observation and try and see if those improvements were helping or not. And you can see it is an iterative process.
Yeah.
So this diagram that you see in front of you isn't a recipe for how to run a sim. This is a conceptual framing for thinking, okay, here's what I might need to have as I think about designing and delivering and collecting data in my sim. But it's certainly not a recipe for how to. Those things do exist, and I think it's important that we do that work also on developing the methods and tools. But this is really, hopefully, captures the way of thinking about it.
And are you aware of people, maybe yourself or maybe people you met in at SESAM? Are there people who are really into the, how do you say it correctly, into the practice of this, of using this, and developing tools and methods and?
Yes. Oh, believe me, there's many people other than me doing much great work in this area. There are there's a number of so from around the world, because we have also interviewed some of the leaders of these programs for some of our other research work. And I think it falls into a variety of categories, but a lot of those teams are informed by and collaborate with their hospital quality and safety teams. And so they hear about the issues in the hospital that need attention, and then they help by thinking about how can simulation help. There's another fairly big group of people who have developed tools for assessing new buildings and for assessing latent safety threats in those new buildings. And so the quality improvement, again, techniques such as the failure modes effect analysis and other things, there's a variety of those. And then there's a number of groups in Canada who are into the clinical systems testing, simulation-based clinical systems testing, which you can also see in that diagram. So I think it's fair to say that a lot of people are doing this, And at the moment, there is a variety of ways in which they're doing that, which I think is probably appropriate because their purposes are all a little bit different.
Yeah.
I think their processes should be tailored to doing that too. So I don't think it's an easy thing to say, here's a recipe, but that's part of why we wrote this article, to say, don't go looking for just a step how-to guide. Actually, probably think a little bit deeply about how do we design and deliver this.
Yeah. Do you know, are there any data or insights or experiences with if you try to run a translational simulation, which, as you mentioned correctly, is not a how do you call it? It's not an easy thing to do in 5 minutes. But if you have thought about it conceptually and operationally, and you use it, I can imagine that, especially maybe testing part or maybe also the exploring part, maybe in a unsafe team, there are people who don't like to be. I know you're not meaning it, but to be tested.
Yes. No, you're right. And I think this speaks to a really important element, and that is any form of simulation. I think we need to prepare our participants very well.
Yeah.
And we need to be crystal clear on our purpose. And I think many people have had at least in healthcare, I can speak for, not maybe as much in your context, but certainly in healthcare, many people have had quite bad experiences in sim, being tested and given feedback that was unhelpful. In some ways, this should be better, because if you think about it, we're asking the people what they think of the system, not telling the people what we think of them. Yeah. So to some extent, this actually could be an easier thing. But because people have had prior experience in that educational paradigm, it requires quite careful communication, quite careful pre-briefing to say, we need your help. We're not here to give you feedback. And in fact, we're not even here to teach you. You may learn something about the systems and about each other. That's great. But what we're really here is to ask your help to help us test this new checklist, to help us test this new space, to help us understand what's going on at these cardiac arrest areas. So you're right, the communication with the participants and their positioning in this process is really important.
That was what I loved about Andrew's approach with design thinking, which, by the way, I was not aware of, but I'm a teacher at a University of Applied Science 3 days a week. I work with students, and I think for 5-6 years, the students themselves, they run projects based on the steps of design thinking on schools and so on. And what I love about it is the co-creation part and asking people to, like, yeah, can you help us? And what are your thoughts? And if I listen to Andrew good, he did a nice experiment with the blood delivery on trauma care, which was not fast enough, and so. But they asked everybody's input and so on, and it was also a kind of empowering.
Yes.
Yeah, so that it was a gentle method. I'm not sure if that's a correct way, but
I think it's a good way of saying it.
Yeah.
I think the other thing I would say, because we have done some of that work in women who suffer postpartum hemorrhage, and we've done a similar kind of work. And I think what it does is it puts the clinician back at the front of healthcare improvement. And I think many of us in healthcare have spent years feeling like quality improvement was something that was done to us. And people said, oh, this is going to be better. You need to do it. Whereas I think what this does, and Andrew's example is a really good one, it instead says, well, you're in charge and you know how well this needs to happen. And you've probably got lots of expertise in how it could be better than it is. Help us out here and lean forward into that rather than waiting for someone else to do it to us.
Yeah. How is this approach, if you implement it, can it also be related to concepts like safety too? I'm not sure what I'm talking about. I just heard the term and I did some research, but it seems in healthcare, or maybe also in aviation, there is a safety 1 and system 2 approach. I also came in police work. I try to make a project around appreciate inquiry, so finding what works. But police was not really interested because they wanted to know what didn't work.
Yes,
It was a
it's a
very
very human.
yeah.
Yes, it seems a very human thing, but I would like to think this can embrace safety two ways of thinking, and so I'll build on it. I think you've done a nice summary there, but we certainly have grown up in healthcare anyway in a safety one kind of thinking, which is something bad happens, let's analyze it and let's try and fix all the things that happened so that it doesn't happen again. Now, that has its place, but it actually then focuses most of the safety work on the less than 5% of things that go wrong. Yeah. And you end up having all your quality improvement informed by the small number of things that go wrong. Safety 2 says, you know what, most of the things that happen in healthcare go right, and it's for a variety of reasons that could help inform our improvement. So you think about something was going to go wrong, but then either because of the knowledge, the skills, or the systems, people recognize that and remediate it or mitigate it such that the outcome is still good. And so this is a positive deviance approach, or this is organizational resilience, I think are some of the words that people put in there. So actually maybe whether it's simulations or whether it's the real world, trying to explore and understand why things go well may be a very rich vein to mine in order to inform our improvement. So this isn't just a matter of saying, Eric, good job, mate, you really did well. This is sort of saying, Eric, you and the team, looks like that was going for a disaster, but somehow you managed to pull it back so that this patient actually did okay. How did you manage to do that? What's the tacit knowledge, skills, systems, organizational resilience that has that? So I would like to think that this kind of simulation, being that it's very embedded and integrated with systems and processes, can help us identify those positive things that we can then say, we should try and do more of that. Yeah. And that's a good source of quality improvement as well.
And is there, how far is safety 2 in healthcare? I mean, is it a no?
I think what I would say is lots of people are talking about it. I think very few people are operationalizing it. So we see in academia, you see in the papers being published, everyone writes this and we all go, yeah, that seems amazing. But it's very hardwired into people, just as you said about the police. Oh, no, we've got to find all the things that go wrong and analyze them. What's the point of talking about the things that go well? And I can understand that. It seems very human. But I would like to think that it wouldn't take too much in our simulation debrief rooms to at least have some of this element, which was to help us understand what goes well here, help us codify that, help us make the tacit explicit so that we can describe it and emulate it in other contexts. So I think the simplest way I would say is, let's say I am there with the teams and maternity who have just looked after a woman with postpartum hemorrhage, and we unearth all these very cool ways that they managed to get the blood transfusion there quickly. Then I can take this to my trauma group debrief and say, the people in maternity are doing this and that seems to work. Did you want to try that? Yeah. So I think that's one, in my world anyway, that's one little way I can try and embrace a bit of safety too. But there's no doubt there's, I think, an untapped potential still that hopefully we will find.
Talking about system and processes, it's from a personal affective background, I think. System and process, I immediately also have a kind of trigger which says, where is the individual human in systems and processes? Because you can even imagine that. Well, let me give you an example from education, because I'm a big fan of Gert Biesta. He's an educational philosopher, and he wrote a beautiful book, The Beautiful Risk of Education, where he compared education as it is right now as a very technical approach. Like, here is the input, that should be the output, and teachers, please do exactly as is requested. So it would even be better in this case that teachers are robots, because then they cannot mess up, like, but real teachers have real emotions and real, moods and so on. How is this approach about systems? If maybe you can get very, very good system and very good processes and protocols and guidelines. And where is the human? I'm not sure if this is a good question for you, but
No, I think it's a very good
Oh.
question. So you're right. It's tempting to think about systems and processes as very transactional.
yes,
I would argue, and a lot of the work we have done is in exploring and shaping the relational and cultural environment in which individuals and clinicians work. And I feel like these are just as much the systems and the environments that we can explore and that we can shape. So we're probably a little bit biased at the Gold Coast because we have an anthropologist on our team, and she has definitely helped us lean into the idea that when, for instance, we're working on that postpartum hemorrhage, one of the things we are trying to explore and understand is the relationships between the midwives, the obstetricians, the anaesthetists, the women themselves and their family, and trying to look at what is this relational dynamics that are going on that we also know shapes performance. So I think that is part of the system. I think that is part of the environment. And to my mind, that is definitely one of the purposes of translational simulation, is to explore and improve those relational aspects of the care that we provide. And yes, I think this is just so important.
yeah. Because when you talked about the systems, I had also in mind, I'm not sure this is maybe more philosophical, but the humans together form the system, isn't it? The system, or is the system just the environment, just the, like the physical space, or
Oh, I think the system is very much the humans in it as well.
yeah,
And I think most of and just thinking back to that diagram and the conceptual fields that surround it, complex adaptive systems thinking would totally embrace the human element of that system, as well as the structural elements of that system and the process elements of that system. And I think you started that question actually talking about learning. And I think probably the way I would pull these things together is that organizational learning is complemented by the individual learning.
yeah,
And both of those have a social and emotional element to them. I think the transmission perspective on simulation has got a sort of limited place now. It's got some place, which is we imagine there's nothing in the head of our learner and then we put something at them and then it's there. But I think most people now realize that learning is a very developmental process, and it has social and affective elements to it, and it certainly has peer and organizational elements to it as well. So I would like to think that we're still thinking hard about learning. It's just the balance has shifted more towards organizational learning while still having some individual learning.
yeah. Are you, by the way, an educator, or are you a healthcare improvement specialist?
Nice question. I think I have grown up as an educator, and I think that informs, well, it certainly affects my positioning and my way of thinking. I think I'm a novice healthcare improver, and I think that's the area that I have tried to lean into over the last 5 or 6 years. Because there's no doubt, as an educator, I could see lots of really brilliant education making some difference, but are still having the potential to do more, because I saw that there was a ceiling in some situations. I would see us train people very well and watch other people do excellent education. But because of system failings, there's still being issues in terms of the ultimate quality and safety of our performance for the patients. So yes, I'm still very happy to own being an educator. I still rather like that way of thinking. But I also know I probably will contribute a little more if I can shift some of my thinking and work towards this healthcare improvement.
Great. It seems to me, by the way, that we started out with how do you call it, behaviorism and the power of the environment. Then via Bandura and others, the individual empowerment and agency came, and now it seems the power of the environment is back again in some way. Maybe maybe better balance. Yeah.
Yeah. You're showing the depth of your reading and conceptual understanding there, Eric.
Can I ask you one or two more short questions before?
Yes, of course.
Because and I have to, maybe I've put up on the where could I find it? You wrote a article. Maybe it's this. You wrote a blog. No, it's not this one. You sent me the blog with the short version of the article. Maybe. Oh yes, I've here. I think. You know what I'm talking about? You don't.
I think so. Was this the IceNet blog? The
Okay.
International Clinician Educators Network blog?
Yeah, the blog. Well, I think I can find it. Talking about systems. I think try this one otherwise. Yes, beyond education, translational simulation to support healthcare, but now, well, I cannot share my screen, but I will. In the end, you gave some advice about for people. So you state here this theory work is all very well, but what does this mean for the simulation practitioner based in a health service? And then you say a couple of things. Keep doing your excellent simulation-based education and training. This is a valuable role, so keep going.
Yes. I certainly don't want people to think this is instead of simulation-based education.
Exactly. And then knock on the door of your health service quality and safety team. Maybe we can work together on a project where simulation can be a helpful test bed for plan changes. Can you just elaborate a little bit on that?
Sure, yeah. So I think one of the things, both in some studies we've done, but also in personal experience, is that just as you said, many of us grew up in education and we're not aware of all the methods and tools and perspectives and ways of thinking that there are in contemporary healthcare improvement. And we can try and improve ourselves. We can try and learn and read more and understand some of those things. But I think we also should just be collaborating with some of the experts in those areas. So I might be the simulation expert, but it's probably a good idea if I go to the quality and safety person in my hospital and say, let's have a conversation about this particular issue. This is what I think simulation could help. How would you think about this issue, and how might we blend those two things? So I think we may find some new friends with this kind of simulation because we'll be working with slightly different people.
Yeah, great. And by the way, what does translational mean?
What does it mean?
Yeah, what
how
is
do we get that word?
I just forget the word.
Yeah, sure. So I that word I chose from the world of translational research. So everyone understands there's bench research, basic science research. Translational research is the kind that takes the work in the lab into the real world and says we're translating these findings and these things that we're doing, and our work is actually making sure they work in the real world. So you can see the analogy I would see with simulation, which is it may be fine to do all this stuff in the sim room, it may be fine to do all this stuff with the doctors and nurses in their training, but how are we translating it to the real world? And that means we need to focus on the systems and processes as well.
And the transfer, I think, is again based upon educational principles, learning psychology, and so on. Eh?
Totally, yes.
Yeah. Did I forget to ask you some questions about translational simulation?
I don't think so. I think we gave a fairly good wrap of what we mean by that and why we call it that, and the fact that it is a conceptual framing, not a recipe or a roadmap, or even just a term. It's meant to be this is a way of thinking about simulation programs with that focus.
Well, let's talk again about in 5 years and see where we are.
Yeah, well, I'm pretty excited at the moment because we're going to do some work with a company called Laudel, who make a lot of simulation equipment. They're based in Norway. And I think one of the things that is missing for simulation practitioners trying to do this work is enough, in particular, technical and software support to do this kind of simulation. So I'm imagining, and if we've been in discussions about developing tools that people could use to support them through this process. So if you think about it, particularly with artificial intelligence now, there could be a phase in which you describe the problem that you're trying to work on, you input some of the data on performance that you've got from the real world, and then the system helps you, like the software says, okay, you should think about running some simulations like this. Here's the list of stakeholders you probably need to talk about with those simulations. And here's the outcomes you might want from that first round.
Yeah.
And that same software could then design those simulations for you, or at least a basic set of simulations. It could advise you on what tools to run, and it could help you then with data capture as you run them, whether that's a QR code from the people participating, inputting their view of whatever it is that you're testing, whether it's observational data like time to do something or other. And then ultimately from that data, it could produce a report that says, here's where we're at now, here's either the next round of simulation plan, or here's a report that you can now send off to the senior leadership of the area with some recommendations. So I think that would help. I don't think we can codify all the process, as we've said before. I don't think this is a cookie cutter thing, but I think there's some core elements that we could support practitioners if we had a suite of IT-enabled tools to help people with that design and delivery and data collection and simulation. So yeah, that's my project for the next 12 months, is to see if we can move the needle a little bit on this on this process. Yeah.
It also seems to me that especially in the beginning of these AI projects, it's very important to have the right people on board, because you can easily see if they are only technical, or if they're only economical, or if they, the human input
be rubbish.
The human input is important in the design process of these tools also.
Totally.
Yeah.
Yes.
Well, thank you, Victoria, and
thank you, Eric.
I hope to speak to you again. And I will
yes.
end this conversation, then I say goodbye in private. Thank you for listening, and as Victoria says, happy simulating. Happy simulating.
Thank you, Eric. A pleasure.
Bye-bye.